All right, hello and welcome, my friends. Let me know if you can hear me. Howdy doody. Wow, I can't believe I got this many of you to log on early. That's pretty cool. I think my windows are set up here. I'm surprised most of you guys didn't try to have a mass exodus after my exam. Say, you know what, I'm not gonna watch him live. I'm not gonna give him the views. Well, that's okay. So I got about 20 of you guys in, so I'm gonna go ahead and talk about the exam a little bit. I will come back to this. Let me start recording. Most of us probably still licking our wounds. Yeah, boy, that exam was something else, huh? That was not what I expected to have happen. But you know, these are unprecedented times, and you know, it is what it is. However, I do still think there's plenty of learning opportunities in order to talk about the questions that were high miss, because when I see a high miss question, I generally will kind of look at it from both ways. I say, well, was there an issue to where the students did not receive the information correctly or in a way such that they could act on it appropriately? That's a fault on me. Or was it something on the student's end, which is more difficult to determine without it being on a case by case basis? So I generally default, especially depending on the stats and how they turn out. I generally will default to, well, maybe it was my fault. I didn't teach it appropriately or teach it effectively. Yes, the world is that's what it feels like sometimes. You know, the weight of success is heavy indeed. So anyway, so I have the exam stats pulled up here. I'm not going to show you obviously because I don't want to give away all of the exam for people to use for next year or something like that. I have to throw out all the questions. So, but if you have questions about the exam, feel free to pop it up here. I'll be more than happy to talk about it. Or if we uncover something in the meantime, if you have a question that comes up based on what we discuss here in the next couple of minutes, and we can talk about that too. I'll also talk about the prescription assignment. Oh yeah, my other thing, I wanted to apologize. I do not have your prescriptions graded. I know I said that very confidently I was going to do that in the announcement yesterday, but I failed you, and I'm going to give you my mea culpa. Turns out sometimes children do not cooperate with your plans to grade all night long. It usually takes me like 3 or 4 hours to get all those done. So I will do that tonight. Hopefully they will sleep and not be up and be sick and stuff. Sometimes they just have a belly full of chocolate milk. They decide they don't want to keep in their belly anymore, and things, yeah, not great. Anywho, so let's talk about the exam real quick. Let me see here. And I'm not sure if you guys are familiar with a term called point by serial. Point by serial is something we use when we are describing the performance of a test question. Basically, if you were to line up everyone in terms of rank order, how they did on the exam, and you guys can see that on Canvas, which I hate because people know kind of where they're at in the pack. But you have people that are high performers, and you have people that are lower performers, and you have people in the middle, right? And so on a test question, it'll tell us, okay, what are the percentage of people that pick the right answer, and then all of the distractors. And if all the people that did really well in the exam pick the right answer, then it gets a positive point by serial and goes up, basically. If there was like a miss key and all the people that did really well in the exam picked the wrong answer, which was technically correct, then actually be a negative by serial. And so we typically look for things that are positive. And it kind of tells me that, okay, well, then if it's positive by serial, then it's probably a good question because the people that did well got it correct, right? But sometimes, kind of some goofy things happen. Especially if people have a misconception, or if I explain something poorly or something like that, you can run into some issues here. But let's just talk about the first one that came up as a high miss, just so I don't waste everyone's time here just pontificating. So the first one was talking about, and this is a new question I wrote. I was trying to test your knowledge here in terms of like how we need to be careful about dosing medication in patients that have various conditions or special conditions. There's a case of a child with CP who had contractures. I was wondering, like, and he's very low in terms of his weight for his age, and so what was the most appropriate thing to do in terms of dosing this patient, right? And so one of the things that was on there was talking about body surface area and being able to get an accurate height and weight. In this case here, I was trying to illustrate that this is a patient who would have a difficult time getting an accurate height in that case there. So it would be difficult to get an accurate BSA, and that could lead to some misdosing. So that was the point I was trying to get at with that one. A lot of people pick that one, and however, BSA is typically really good to take into account height and weight. In this case, for this type of patient, it would be more challenging, right? The other thing, though, that was correct was that you need to make sure that things are being put in the correct units. It's easy to screw up and get pounds put in for kilograms and vice versa. And you could have a 220% overdose, or you could have, the opposite where you're underdosing the patient. So that's the takeaway I was trying to get with that question there. Let's see the next one. Okay, so there's another one talking about basically drug-drug interactions. This is something I want you guys to think about, is that drug-drug interactions just doesn't lie with the CYP enzymes alone, right? You have to think about all the different factors here. So drug-drug interactions can be certainly metabolism interactions like you would see with cimetidine, which makes sense. I think most of you guys already have that hammered into you now. That is going to cause a lot of drug-drug interactions. But think about, too, like, what about in the GI tract? What if something binds up another drug and prevents it from being absorbed? That's a drug-drug interaction, too. And that's something you would see certainly with a lot of, like, your bulk-forming laxatives, like your psyllium husk and things like that. So it's really important to consider separating those medications out to prevent, a drug from not being absorbed because it got stuck in basically that bulk forming laxative there. But think about functional sort of antagonism between drugs as being interactions too. Consider if I have a drug that increases heart rate and then they're also on a beta blocker that decreases heart rate. That's antagonism. That's a drug-drug interaction. I want to kind of expand your minds a little bit to think about how you think about these interactions, because when you're investigating these things for people, when you're taking care of them, you want to be able to identify those such that you can try to make good interventions like discontinuing medication or changing it or something like that. So someone says, so if not the BSA, what was the better option? The better option was to make sure that when you're having patients that have, values of weight that look incorrect, make sure that they're being put in the correct units. Kilograms, pounds, whatever the case may be consistent about it. We usually stick with kilograms here in the, how do we do, here in the US, we still use the imperial system for a lot of things, but medicine, typically it's going to be the metric system. So typically keep it with the kilograms if you can. Someone said, so how would it be hard to measure the height of a patient, or did I misunderstand? Think about it. If you have contractures, their legs are contracted, they're going to be difficult to get an accurate height. You can't just stretch them out, right? So that becomes more difficult. Early babies are hard to do it. Getting a toddler to stand still so you can get an accurate height. I see heights that are put in incorrectly all the time. You'll have patients come in for different visits, and they'll have different heights of like a couple of centimeters, even though it's only a couple of weeks that they're there, up and down, right? Differences both up and down. So in that case, something's going on. Maybe they had shoes on, maybe they didn't have shoes on. Something's happening, right? So much info. Yeah, there was probably a lot of info, but it was even only 3 sections, so it's even less than normal. But let's see, next question here. Okay, so one was about the effects of acetylcholinesterase inhibitors. You're looking at drugs for Alzheimer's. So I want you to remember, so if you have acetylcholine, right? Acetylcholine activates, as someone says, so see, Kyle's saying, so BSA is not correct because the question height weight could not be calculated correctly. That was what I was trying to get at. I'm probably going to reword that question or rework it for next time. So I'm going to work on that that was one of the givebacks. Okay. CP, I had to measure like the head and then add that to the measure of the length of the torso and the measure hip to knee. Right. So thank you for backing me up there, saying it was really difficult. But, like I said, when I write new questions, I always use this as sort of a testing ground. And, if it was a bad question, it was a bad question, and I can do those givebacks. Anyway, so when looking at acetylcholine, remember it can activate nicotinic muscarinic receptors. acetylcholinesterase breaks down acetylcholine, right? So if I inhibit acetylcholinesterase, I'm going to be inhibiting the breakdown of the acetylcholine. Thus, I'm going to have a ton more acetylcholine around. More of that acetylcholine is going to be activating those nicotinic and muscarinic receptors. So I want you to know that if you have something like an acetylcholinesterase inhibitor on board for something like Alzheimer's, you're going to expect to see cholinergic symptoms, right? And that's where we get into the dumbbells that I mentioned before. So things like, defecation, urination, meiosis, things like that, right? So in the question, you had a couple of different options. So you had things like dry mouth, tachycardia. Well, you wouldn't see that with an acetylcholinesterase inhibitor because you'd have more acetylcholine that would slow down the heart, that would cause the mouth to salivate. It would not cause constipation, but diarrhea. So try to keep those in mind. Students frequently have a difficult time with the autonomic nervous system, and it not learning that system, but if you alter that system, what kind of things can happen. And so that's why the vomiting in that case there would be the correct answer. Okay. Let's see, what's next? So which of the following, let's see. Okay, so there was a question also did a give back for, it was asking about a patient who recently had a varicella infection, that chicken pox, and then they were going to be getting, which of the medications would be contraindicated. The point there was to focus on the Ray's syndrome and to remember that things like mesalamine and sulfasalazine, they get broken down into 5-ASA. They get broken down into aminosalicylic acid. So there is some theoretical risk and potential risk for Ray's syndrome in that sort of situation there. They wouldn't necessarily be, a lot of you put down infliximab. That wouldn't necessarily be a contraindication if it was a past infection. If there's a recent history, they've already resolved. No reason they couldn't get infliximab in that case there. So that one I did give back because obviously there was some misunderstanding there, probably from me teaching it to you. So that was that. Let's see what else. One about, it's just another case. Actually, I had two questions that are pretty similar. Another about the drug-drug interactions. In the case of GI meds causing decreased absorption of medications. Remember, a lot of your antacids can do this too. It's not just the bulk forming laxatives, but it's also things like calcium carbonate and aluminum hydroxide. And all those things can prevent absorption of medication because they will chelate them. They'll bind them in the GI tract. So that leads to lower levels. A lot of you actually pick cimetidine, but that would cause increased levels of affected drugs, right? Because it's a CYP inhibitor. So it's important to realize which ways the levels are going to go for affected medications based on the interaction. If I have a CYP inhibitor on board, affected medications will have their levels go up. If I have an inducer, levels will go down. Again, that's a pretty common challenge for a lot of students, is keeping all those kind of interactions in mind there. This is another point. Again, I took this one as maybe poor communication on my part. So this one about a patient going on fingolimod and they need the flu shot. So remember, when you're dealing with patients with who are on these biologic agents, right, that are immunosuppressive, the main thing you want to know is that don't give them live vaccines, because the risk of them getting the infection is the problem there, right? So live attenuated, don't give it to them because they can have the infection itself. They can get the flu from that in that situation. Inactivated vaccines are okay to give, okay? Now, the patient's immune system may be compromised to the point where they don't get as good of a response to it, but they still can get some response. I mean, they do develop some degree of immunity to it. So if I had someone who is on one of these immunosuppressive drugs like fingolimod or infliximab or something like that, I would not take them off of that drug to risk a relapse of whatever condition I'm treating. I would go ahead and give them the inactivated form, knowing that, yeah, their risk for getting flu may be a little bit elevated because I gave them the inactivated form and they're immunocompromised. However, it's better than not giving them any flu shot. And it's also better than not giving them the live attenuated, because that could then cause the infection. So there's that one. Let's see what else. I think that's it. I think I hit all the main questions there. So anything else? I'm doing it within the allotted time, which is great. Any questions from you all? Let's see here. I feel like PowerPoints for this exam prepared us to pass, but not succeed and or do well. Interesting. I think there was a lot of implying on the exam that the majority based on average score we're not ready for. Well, yeah, I guess if that was your sense on it, let me know what I can do to try to improve these for next time, right? Or if you're like, this is not very clear, let me know. And that's another thing I want to just kind of say outright. For I can change things midstream, right? I don't have to wait until the next time I give this class in order to modify things. So if you feel like something is not being done correctly, or something could be improved, like, I prefer to know earlier. I don't want to find out on my evals at the end of the semester that I could have been doing better the whole time. Let me know. If you want to do it anonymously, if you want to do it publicly, send me a pigeon, a carrier pigeon, smoke signal. I don't care. I'll take any message I can get. But let me know, right? I want to make sure that I can teach you the best way that you learn, which may not be the same for all 61 of you, but I want to be able to try to teach you guys the best I can. That's my goal here. Someone said, "Oh, thank you so much. You guys are really super nice." Yeah, no problem. Let's see. Challenging in terms of applying the material, but I think you taught it very well. Well, thank you. It's very nice of you. Yeah, application is always hard, right? You guys are so sweet. Application's tough, but remember, this is the trend, right? We want to talk more about application than simply memorizing, well, this drug's a beta blocker. Okay, well, anyone can tell you that, right? This is the point where we're getting at talking about how to actually decide what drugs to use, when not to use them, how to use them, etc. So that's kind of the general trend of things. Now, someone said Ron Swanson would never need a prescription because, he's on the bacon steak diet. I probably agree with that. He didn't say he wants most of the bacon. He wants all of the bacon, right? Anyway, let's see. Difficult for other classes when we're not able to find out what we did wrong. We may not have understood. Yeah, I think these high misses are good learning opportunities for you guys, and so that's why I like to talk about them. Obviously, I don't want to give away the whole question, but it at least gives you a means for trying to reflect on that stuff. And it's tough because you don't get the feedback because you're still distant, and that's a really big challenge. That's a big detriment to you guys. So again, you guys are all doing awesome. You're in a very tough situation, and I really appreciate you guys sticking with it as best you can, right? This question's about the we'll talk about this in rooms. I'm gonna hold off on that. I'm gonna get back to that a little bit later on there. Let me see. What other things do we have to talk about? Oh, I do want to talk about the prescription assignment. If I can find the rubric. Any chance we could review future exams as well? Yeah, I usually either do it in an announcement. I figured there's just a lot here, but yeah, I'll do this for next time too. But if I don't say anything about it, remind me, and I'll do that. Where's my rubric at? So the next prescription assignment is going to be a little different than the first one. That's why I want to talk about it briefly here. And it's going to be more based on writing inpatient orders for just inpatient orders in general for patients who are getting medications. Of course, I can't find my rubric here. I'm just going to pull it up on Canvas. Anyway, so you'll see there that you're going to be writing a couple of different inpatient orders for someone who I believe is either has like nosocomial pneumonia or something like that. And so I wanted to go over the rubric with you just so you can kind of see what I'm looking for and what kind of things would be how I'd actually write these things out. This pops up. All right, so you guys should be able to see the thing here. Keep in mind, we're not doing the first half of this. We're going to be using the second half of the rubric here. Okay, so basically, what you're going to find, I can't see it anymore. Where'd it go? I had it for a second there. Here we go. All right, perfect. All right, so you can see the rubric here, hopefully. And basically what you're going to find is that this is how you're going to write out all of your orders. So basically there'll be one medication order per box you're going to write on here. You just need to start out by writing out the date and time. You only have to do that once. The whole point here is to basically encapsulate your orders from the time you write it down to when you sign it. That's all your stuff, because you don't want other people coming in writing things in between, which has happened in the past. Biggest things with these is that making sure just following the rubric, make sure all the points are going to be there. In terms of writing things like fluids, here's how you end up writing it. So if I did something like D5NS with 20 a K, you can write as 125 mLs per hour, right? This is typically the only thing you're going to be writing actual mLs amounts of is going to be IV fluids typically. Everything else should be written in the dose. So if I want to give something like excuse me, if I want to give something like lorazepam 1 milligram, you don't need to figure out how many mLs that's going to be, right? Because the concentration may differ from organization to organization, from product to product. You just put the milligram amount. So for something like this here, you could write lorazepam 1 milligram. Note the route is going to be put here, IV push. Note the frequency, so Q2 hours as needed. And then because it's as needed, you're going to put the indications as well, okay? So don't just write something PRN and not put indications, because even though it may be obvious to you, it may not be obvious to nurses and other people who are acting on those orders. Make sure you're clear on that stuff. If something can be given push, you can write IV push. That's fine. You can just write IV. That's reasonable. If something needs to be given over a long period of time or a certain duration, you should include that as well. So for instance, here like Rosef or vancomycin, if you recall, if you give vancomycin too fast, you get red man syndrome, right? So if I wrote vancomycin IV push, or if I just wrote IV, then it might be given way too quickly. So it's good to specify for certain cases to give it over, say, 2 hours, okay? Now, this is a little archaic. You may be working in hospitals that have EMR, so this may not apply in every single place you go, but it's still good to get the practice of handwriting this stuff, to at least get the experience of doing handwritten scripts or handwritten orders, like you might do in some places. Certainly in a lot of clinics and offices, private offices, you may still be writing something similar to this. Make sure you sign at the bottom, put your credentials on there and all of that. So this is how I'd want to see it. Note, you don't have to put down the date and time for every single order. Just do it once at the top and you're fine. The other thing too is if you want something to start right now, you can just write the order like this and it's fine. If you want something to start later, you need to indicate that. And so you can say, hey, start this medication at this time. You can include that information if you want. There'll be one later when we cover surgery stuff that will be more, that'll make more sense when we get to that point. But anyway, and the other thing too, if you're going to be writing medications in terms of like a continuous infusion, like I think we have a few on the ones I just published, where it's like you're going to do like an opioid infusion and a benzodiazepine infusion, right? In those cases there, you can write out things like, okay, let's give 1 mic per kilo per hour, whatever the case may be, but make sure you include the total amount for that patient as well based on their weight. So that should be included as well. So any questions on that so far? Apologize for coughing. Someone said, can you give us more examples during class regarding test style questions? The Vanco question, inactive form is never mentioned in class. I think it was confusing for us. The vaccine form. I thought I mentioned, we were talking about live versus inactive vaccines. I may not have it on the slide necessarily, but we will, so the stuff I say is also testable information. So, but yeah, I'll definitely try to include more test-like questions for you guys. Selena was saying, will the assignment give us direction on how long we have the patient for? So that's a good question, right? So when you're writing these types of orders here, you may not know how long the patient's going to be in for, right? Or how long they're going to require it. So if you write orders like this and don't put a duration on it, it's going to continue until basically the heat death of the universe, right? Forever. So, which is normally okay because you're probably going to come back and see that patient the next day or whenever you come to see them next. And you can DC the orders at that time, discontinue them. For some things, you only want certain duration. So for instance, if I was writing an order for Toradol, IV, I would put a duration on there, say for X number of doses or times 3 days, times 5 days, whatever the case may be. So unless I give you specifics on that or you see there's a reason why you want to put a specific duration on it, you don't have to worry about it, right? This would basically give this person vancomycin every 8 hours until they die, basically. But you would be coming back in and reevaluating and say, okay, well, they probably only need 7 days. I can stop it on day 7 and they're done. So hope that makes sense. Okay, so we are talking about rheumatology stuff, I think. Do we get started on that at all? Oh, so someone's asking for the prescription assignment. You said taking the weight into account. Yeah, so some stuff you'll have to figure out what the dose they're going to get is based on their weight. So you can look that up in LexiComp or wherever and basically say, okay, well, they're going to get 0.1 milligrams per kilogram per hour, you'd want to figure out, okay, well, the patient weighs 70 kilograms, so they're going to get 7 milligrams per hour, basically. So you can just do those simple calculations and include that on there so that I know you're doing the math correctly and making sure the patient gets the right dose. Otherwise, you can get discrepancies there and cause issues. So, okay, so let's go back to our lecture. We're only about 9 minutes in, so it's not too bad. Let me know if I'm recovering old ground or anything. I think we did not get a chance to start this section yet, so I'm gonna go ahead and just start it off here. So we're talking rheumatology, and a lot of this stuff is kind of old hat for you at this point. You know, we've talked about the immune response quite a bit. We've talked about UC and Crohn's and all of that, and how that's basically the body having an inappropriate response to itself. Essentially, it recognizes itself as foreign and wants to attack it, right? And so we've already seen a few drugs that can affect that, like things like infliximab and you know, methotrexate and drugs like that. We're going to see that there's a lot of crossover with a lot of conditions that fall into that autoimmune sort of category. So like RA, SLE, things like that are all going to fall into the same sort of heading here. It's important to understand the immune response and know kind of the different players here, because if you can know the process that's happening there, you can know how to interrupt it or inhibit it to a degree to try to prevent further damage from happening here, right? Because if left unchecked, all kinds of bad things are happening here, right? So for instance, like all these neutrophils are being attracted to the site. They're releasing all these reactive oxygen species like hydrogen peroxide and causing further damage. So the name of the game for a lot of these patients here is going to be a mode of where we're trying to manage their symptoms, but more importantly, we want to try and tamp down that immune system to try to help slow progression of the disease, right? And that'll be really important for rheumatoid arthritis, which we're going to talk about first here. We already know ways that we can affect the inflammatory cascade. We've already seen several of them. But just to kind of reiterate, recall that when dealing with that inflammatory cascade, a lot of this is happening intracellularly as well, where we have the arachidonic acid pathway, right? Remember, we have things like the phospholipases kind of coming from the cell membrane, being converted to arachidonic acid, and then can be acted on by a variety of things like COX, for instance. We're going to talk about cyclooxygenase pretty extensively here, and how that produces prostaglandins and all kinds of other inflammatory cytokines. And again, this is a perpetuating system here, where it kind of just has a positive feedback loop to a degree, and that's why you see such severe inflammation in these patients here, again, against yourself, which is, again, obviously not great. So I want to talk about RA first, and we're going to compare and contrast that with osteoarthritis, because I want you to kind of look at the differences in the pathophysiology, and then that will make sense in terms of how we manage it differently, how we treat it differently in terms of the medications we're going to use here. I know you've already talked about rheumatology stuff. I think you had an exam on that today, so you're probably pretty well versed in this. So I'm not going to reinvent the wheel here. But again, it's this progressive joint destruction that happens over time due to this increased inflammation, right? And so we're going to see that eventually you're going to get erosion and destruction of that joint. I'll never forget, I had this like teacher back in elementary school, and I always like, she had these like very weird hands, and I was like, why are her hands so weird? Like her thumb is like bent almost backwards, and I just had no obviously context for it at the time. But I think back and I was like, oh, that's like classic rheumatoid arthritis that she was dealing with. Obviously, I would not say that to her, because that would be pretty inappropriate and awkward, to say the least. But anyway, so getting into it, we're going to see that there is, a humoral component to this, where you're going to have these formation of antibodies. These are going to help to activate things like, your T cells and whatnot. I'm not going to get into the diagnostics of it necessarily, but we're going to start to see some of these targets here we can affect, right? So we already know cyclooxygenase is a target we can maybe use to help decrease this inflammation. We can see that maybe by inhibiting some of these B lymphocytes, or maybe some other cytokines that are activating these lymphocytes, perhaps that can also be a target that we can use to our advantage as well, right? Once you have these B cells producing these antibodies against yourself, it's going to attract all these neutrophils in, and that's where a lot of that destruction is going to start to happen. They're just going to start to chew through everything, basically. And then, then T cells are getting activated as well. Again, I'm just going over this briefly, because you've probably covered this to a large degree. I'm just kind of focusing on some of the drug targets. The T cells are really important too, because they're going to be releasing things like tumor necrosis factor alpha and interleukins. Those are going to be big drug targets, as we're going to see with our monoclonal antibodies. So I'm going to get into a lot of details on that here in just a few moments. But then, histamine, prostaglandins, we already know drugs that can affect that for sure. And then we'll see the CD receptors are also going to be an important target as well. If you can inhibit those CD receptors, maybe by slapping an antibody onto them to neutralize them, that's going to help to disrupt that cell signaling to try to interrupt that inflammatory cascade. So that way we're trying to just stop the cycle, inhibit the inflammation, and prevent further destruction to the joints, right? Okay, so here's a picture kind of what it would look like. You might imagine. Let's see. I'll go back to these questions here in a little bit. I'll talk about those stuff on the sticky board in a little bit. So anyway, so you can see kind of the destruction happening to the joint itself over time, and you can look at all these different signaling molecules that are being sent around. So by inhibiting these, you're disrupting that cell signaling, and thus those cells won't get activated, at least to as big of a degree. And so that's why we're going to be looking at that as potential targets for our medications here. Now let's compare RA versus something like osteoarthritis, where this is much more of a wear and tear kind of deal. Where we're going to be seeing that things like age and obesity and just general anything that puts extra stress on the joints is going to be the major player here, right? Certainly we know this is a big deal. A lot of people have it to various degrees in varying joints. We know there's a lot of money associated with it. A lot of pain medications get started to treat osteoarthritis, which can lead people down the path of addiction potentially, which you guys hopefully know a decent amount about substance use disorders and whatnot. But if you were to compare a normal joint versus someone with osteoarthritis versus rheumatoid arthritis, you can see kind of the big differences here. Again, the osteoarthritis, they're just having that wear and tear of the cartilage, eventually just having bone on bone rubbing together, and that's activating those pain fibers versus, and again, limited amount of inflammation there versus in rheumatoid arthritis, it's all inflammation. It's all basically the cells themselves attacking that joint and causing the damage being done, right? So with osteoarthritis, again, this is mainly due to articular damage, due to injury and stress over time. There's going to be a disbalance between the production of new cartilage, and this is mainly due to having apoptosis of the chondrocytes happening here. And again, whatever inflammation is happening is going to be limited as compared to something like rheumatoid arthritis. So the treatment is going to be pretty different, as we're going to see here in just a little bit. But again, when you have that bone on bone, you're going to see these nerve endings are starting to be activated, these nociceptive fibers, like the pain fibers, and other chemical irritants. That's actually going to be another target. We talk about substance P here in just a little bit. So, and again, you can kind of see what a arthritic joint would look like versus a relatively normal joint here, right? So this is probably all stuff you've seen already. So let's talk about our goals here. So for both RA and OA, the goals look pretty similar in terms of helping out with quality of life and decreasing the symptoms they're having. Try to slow down joint damage if we can. We'll look at some different ways to do that. Function and quality of life is obviously going to be huge for these patients. And then for RA, because it's an autoimmune condition similar to other ones we've looked at, we want to deal with those flare-ups, deal with trying to get them back in remission, and then slow down that disease progression. Try to slow down and prevent that joint destruction over time, because unfortunately, it's not really going to be something we can reverse necessarily. Okay, so looking at non-pharmacologic therapy, just real briefly, this is super critical for all these patients to get in conjunction with the medications, especially those with osteoarthritis. You're really just kind of putting a Band-Aid on things, so to speak. If you're just using medications for someone with osteoarthritis, they need to get this other stuff done too. So, but it's hard, right? People don't like to go to PT because it doesn't feel good, right? And I can just take a pill and feel better, but going to do pull exercises is painful. I'm not going to do that, right? So your goal as PAs is going to be really huge in terms of motivating these patients to, get out there and do it, because overall in the long term, it's going to be helpful to them, right? Anyway, let's look at the treatment options. A lot of pomp and circumstance to get down to the drugs, right? But here we are. So to look and compare these together, you're going to see the treatment is going to be quite different, as we're going to see. For chronic management of RA, we're going to focus a lot on NSAIDs and low-dose corticosteroids. And then for acute exacerbations, we're going to see that we're going to utilize systemic corticosteroids pretty heavily, just like we've seen with things like MS, Crohn's, and things like that. And then we're going to get into the DMARDs, stands for the disease-modifying anti-rheumatic drugs. So some of those you probably know from Dr. O teaching. I'm going to get into it as well. And then for OA, you're going to see it's quite different, because inflammation isn't the primary thing happening here. It's not your immune response causing the problem. So we'll see some use for things like acetaminophen, NSAIDs. We'll look at some topical options we have available to us. And then for acute problems, acute exacerbations, you may utilize opioids, but obviously we're going to want to be pretty sparing in terms of how often we want to use opioids for these patients, because we know there's risk associated with it. In terms of for knee effusions, pretty similar activity here, or treatment, aspiration, corticosteroid injection. We'll talk about that a little bit later as well. So, as I mentioned with the DMARDs, they are going to be broadly categorized into either biologic or non-biologic agents here. And so this is going to be an important distinction because we're going to talk about how to mix and match these drugs and which ones are good to mix together, which ones are not good to mix together because of their immunosuppressive activity, right? That's always going to be the double-edged sword with this, is we want to decrease inflammation by inhibiting the immune system, but we also don't want to cause too big of a risk for infection, which is always going to be a side effect from many of these drugs here. Regardless, these need to be started as early as possible because, again, they're slowing and hopefully stopping the disease progression and preventing, because it's just not going to be reversible, right? So this is why we want to start as early as we can. And in the meantime, because a lot of these do take sometimes months to work, NSAIDs and corticosteroids are going to be utilized for sort of immediate symptomatic relief. And obviously, corticosteroids, you want to use the lowest dose possible, if any at all. NSAIDs will probably be a pretty chronic sort of cornerstone to their management for the most part. So talking about the traditional non-biologic DMARDs first, there are certainly more than just what I'm listing here. I just want to cover the most common ones, some of the caveats associated with them. You might hear of others, but again, I don't want to go over every single drug out there because we would be here till you guys are past graduation time. So the four main ones I'll focus on for the traditionals are going to be methotrexate, hydroxychloroquine, which has been in the news not recently, but if the past year you've probably heard of it. Next we'll have sulfasalazine and then leflunomide. And then for our biologics, there certainly I'm not going to cover every single one of these that are out there because this is a big sort of cottage industry now. They're always coming up with new biologic DMARDs. There's a ton of them that are out there because there's so many people that can benefit from it. So a lot of companies want to come up with their own version of them. But I will cover some of the more common ones. So things like infliximab, adalimumab, we've covered some of these already. A lot of that same stuff will be applying here as well. And so all of these are going to be anti-TNF. So again, what specific target they're focusing on is going to be important to know because that's the mechanism basically. Co-stimulation modulators, I'll talk about that a little bit later. And then we'll have some other means of inhibiting the immune system by going against something like IL-6 or interleukin-6. Something like tocilizumab and rituximab. And then the newest out of the group, and I kind of picked this one because it was the first one that came out under that heading, is tofacitinib. This is actually what we call a JAK inhibitor, and I'll talk about what that means in a little bit later as well. So we have others that are used occasionally. These are typically for more resistant to treat cases, resistant to treatment cases. But it's interesting to look at some of the things we've used in the past. Even things like gold-based compounds have been used because they do have some immune system sort of activity that are also toxic to a lot of other cells, which is why we shouldn't be using gold if we can help it. Yeah, so these are other ones you may run into. I'm not going to get into these in great detail because they're more of specialty sort of use. We'll talk about the things you're going to see most commonly, right? So in general, the full extent of the mechanism, we don't really know. Like we know what the drugs do, but how they're necessarily working to inhibit this inflammation, all the various effects that it has, maybe not super well known. In terms of the drugs are going to get sort of the best efficacy to toxicity ratios, because that's always going to be kind of the fine line we're walking there between how well they work and then also the toxicities, because they're all going to have their own toxicities. Methotrexate and hydroxychloroquine are probably going to be your best bets, okay? For a lot of patients, they may just be on methotrexate and corticosteroids for years sometimes before they kind of advance to a point where they're going to require other therapy. So that's probably the first stop for many people is methotrexate and corticosteroids. But sometimes you may find patients require multiple DMARDs. And so we'll talk about how we mix and match those and try to make sure we're using complementary mechanisms wherever possible. So what we'll see is methotrexate is probably going to be started first line for most people with RA. Again, it's an old drug. It's been around forever, so we have a lot of information about it. We have a lot of experience with it, and it will be a good component for multiple drug regimens. So this could be a backbone to other drugs being added onto it potentially. Let's see. Anything with NIBs or kinase inhibitors. That is correct, right? So remember we talked about, I'm so proud of you guys remembering protein kinase receptors. If you recall, protein kinases were cell signaling molecules protein kinases are receptors that cause cell signaling cascades to happen. This will be the same thing. So if you see a nib, just like gefitinib or nilotinib, they're all going to be protein kinase inhibitors, basically. So good catch there. So anyway, talking about our traditional DMARDs, they're generally going to have a slower onset of action. So non-biologics are slower in activity, about 3 to 6 months, than you're going to see with some of your biologics. Okay. Some of them are a little bit faster, so things like methotrexate, sulfasalazine, leflunomide, we've seen these before, are going to be a little bit faster. With biologic DMARDs, because their mechanism is such that it's going to be binding up a lot of those inflammatory cytokines right away because they're antibodies, you're going to find that they are going to be useful within a couple of weeks, which is nice. However, all of these are going to inhibit the immune system to some degree. So especially with the biologics, you want to make sure you get your TB test done beforehand. That's probably going to be a piece of routine workup for these patients regardless. So it'll probably be already done, but you can look for a recent test. And then any vaccination should be up to date because you want to get those done prior to starting your biologic DMARDs, especially, but we'll look at some considerations with that as we go forward. Okay, so with vaccines, you want to give these beforehand, if at all possible. Biologics especially, but I would say with the traditionals as well. So again, killed or recombinant vaccines, so this is kind of re-illustrating what we're talking about just before lecture started. These can be given during therapy. So if you have like the intramuscular flu, which is the killed form, hepatitis B, those are fine. But don't give them live vaccines because that risk for them getting the actual infection is going to be higher. Okay, so just to re-illustrate that point here. And in some cases, if they have this or if they have RA, they may actually be recommended to get certain vaccines earlier because we know this immune system suppression could potentially lead to infection, so they want to protect them sooner. So something like herpes zoster, they get at 50 instead of, say, normally 60 as an example. So let's get into the traditional DMARDs. Fortunately, a lot of this stuff is going to be reviewed from either earlier in this semester or last semester. If you recall, we talked about methotrexate briefly in GI, but we talked about it a lot in terms of oncology treatment. It's a folic acid antagonist, basically. It prevents your cells from producing new nucleotides through the activity of inhibiting folic acid recycling, basically. And so that makes sense why it'd be kind of a slow starter in terms of its activity because it doesn't do anything to those existing cells that are already there and working to cause inflammation, but it helps to inhibit the reproduction of those cells, right? So it's helping to slow down that production of new white cells to attack those joints, right? So, and again, I don't really care that you know the specifics about, which carbon groups it's inhibiting, but just know that it's inhibiting dihydrofolate reductase. It's inhibiting the utility or utilizing of folic acid within the cells. Okay, so it can't produce new DNA. Here's a picture of what this would look like. You can see what tetrahydrofolate looks like normally. Compare that to methotrexate. They look pretty similar to one another. And you can imagine how this can kind of come in and basically kind of gum up the works, so to speak, and prevent that recycling of folic acid and prevent it from working, right? So toxicities we're pretty familiar with. Bone marrow suppression is the big one. Keep in mind, though, the doses that we're using are much lower than what you would see for use for something like leukemia. So you're not going to see as great of a degree of immunosuppression as you would for someone getting this for chemotherapy purposes, right? So someone was asking, just to clarify, non-biologics are methotrexate, hydroxychloroquine, all of that. Yes, the traditional DMARDs are the non-biologics. And so I'll make sure that's pretty clear when we make that transition from one to the other here. Again, all of those fast dividing cells are going to be affected. So your GI cells, your hair cells, bones, marrow cells, all those things can be affected equally. So it's important to keep that in mind as common side effects for people getting methotrexate. You want to also monitor their renal function. This is really important because of the fact that you can end up having levels being elevated if they can't clear it, and that can lead to further immunosuppression. So we want them to be a little bit suppressed, but not so suppressed they're going to be at risk for things like, PJP pneumonias or something like that. So that's why you want to really be careful there. Watch the renal function. Make sure patients are not going to get pregnant while they're on this. Now, this is less of a risk because RA usually starts a little bit older in life, but not to say it's not a zero risk. So, and in fact, methotrexate has been used in the past as an abortifacient along with misoprostol. And so we know this is going to be a big problem. Little babies, developing fetuses, they need folic acid to produce new DNA. So this is going to be contraindicated for those patients there. Also, watch out for patients with liver disease. monitor for liver functions because you can see some issues there. And obviously your CBC would be something you'd want to monitor as well. All right. So as I mentioned, methotrexate, most commonly used DMARD, you're going to see out there, pretty effective, relatively fast onset of action as compared to some of the other ones here, and relatively acceptable incidence of adverse effects, especially if you can keep the levels in range for what they're going to need. A couple of different routes you can give this. I see most people probably taking PO, but I've seen some people get an IM once weekly. That can be helpful for compliance issues if patients have memory impairment or something like that. And again, make sure you're monitoring for renal, liver function, and that CBC, right? We're going to be obviously more frequently at first to see how they're going to respond. And then you can extend it out as well as time permits and as their levels have been pretty stable there. Generally, we'll also recommend giving folic acid 1 milligram every day, or they may actually get just a once weekly dose of 7 milligrams. That is to try to prevent some of the toxicity. Again, how effective that is, I don't know if they've done a study necessarily to say you should do it, but it helps out all those other healthy cells that are not rapidly dividing to help them, function relatively normally. So this won't inhibit all the side effects, but it may help a little bit, right? And folic acid they should be getting in their diet anyway, right? Okay, so next we have leflunomide. We actually talked about teriflunomide back when we were talking about MS, I believe. This is a metabolite of teriflunomide. And actually, I'm sorry, teriflunomide is a metabolite of leflunomide because this is a prodrug, right? So this gets broken down into that and basically inhibits pyrimidine synthesis, right? So similar to methotrexate, you're not producing new nucleotides. Can't have dividing of those white cells, although the mechanism here is a little bit different. Instead of looking at methotrexate, this is inhibiting it through other means, okay? So overall, you're going to have decreased lymphocyte proliferation here. What you're going to see with this one is that it also has relatively fast onset, and hopefully is going to have pretty good effects at helping out with their symptom management and getting some of their function back there. Overall, pretty efficacious, or will be similarly, mush mouth today, it will be similar in activity to methotrexate. So I was interviewing today, so I kind of talk a lot during those, and that leads me to have a tired mouth now, but that's okay. Anyway, diarrhea is probably one of the most common side effects you're going to see with leflunomide. Again, this is due to the GI cells being affected here, but again, you're looking for hepatotoxicity, you're looking at the CBC for hematologic toxicity. That all makes sense based on the action of the drug itself. This is also very teratogenic, and if you recall, we talked about it undergoing that enterohepatic recirculation. So even though they stop taking the medication, it may be months before their levels drop to a point where it would be safe to get pregnant. And so that's why we do that cholestyramine washout. Use that bile acid sequestrant to bind the drug up and get the levels down quicker. Again, pretty similar monitoring parameters. No renal dysfunction to worry about with this one. So that is one benefit that it has over something like methotrexate. Okay. So someone said, this is a good point here. Someone said, why does giving folic acid not counteract the intended action of methotrexate? Well, basically, it's because by inhibiting that dihydrofolate reductase, the folic acid can't be used in the first place. So that's actually an interesting point, because if we have someone who had overdosed on methotrexate, for instance, say they got too much of it, or say they have renal dysfunction, their levels are elevated of methotrexate, we can give them folic acid all day long and it won't do anything because the cells can't utilize it because that dihydrofolate reductase is being inhibited, right? So instead, I can give the activated form, and if you recall, we mentioned this back in talking about oncology. You can give folinic acid, which is the activated form. The cells can readily use that without the need for dihydrofolate reductase, and you are able to utilize that form. So if I've had a few cases like this where I actually had someone who was injecting themselves weekly, having sub-Q injections of methotrexate weekly, but they had a little bit of memory impairment and they goofed up and they gave themselves a double dose of methotrexate. And again, it's a once weekly thing, so it was a fairly decent dose they had gotten there. And we ended up having to utilize folinic acid, otherwise known as leucovorin, until the levels dropped down to a relatively safe level, so that way it doesn't cause too much immunosuppression. So, but very good point to bring up there. I appreciate that. Anyway, so next we have hydroxychloroquine. So this is probably, if you're looking at in terms of efficacy, the wimpiest out of the bunch, but is also going to be the most tolerable because it has the fewest side effects as compared to things like methotrexate and leflunomide. This one's mechanism is a little bit different here, and it makes sense why it would be a little less efficacious because it's not directly inhibiting reproduction of the white cells of the immune system, but it's basically trying to prevent the cells from coming to the site of inflammation where they get activated. So inhibiting neutrophil locomotion, preventing the chemotaxis of the eosinophils to the site of inflammation. All those sorts of things are going to be useful to help tamp down that inflammatory response, but not as effective as something like methotrexate, right? But also, you're not really going to see a lot of myelosuppression because the immune cells are able to replicate fine on their own. No hepatotoxicity or renal insufficiency. So this may be a good add-on agent to something like methotrexate. Rarely would you see it be used by itself unless it's a very mild case of RA. But overall, this is beneficial because it has less monitoring associated with it, right? Anyway, some other things you might find with this, you do want to look for changes in visual acuity. So you definitely want to check this at baseline because there has been cases of retinopathy associated with hydroxychloroquine. So you want to watch out for that. And then in terms of some dermatologic reactions, you can get here things like increased skin pigmentation, which you can kind of see some discoloration here, rash, things like that. So overall, well tolerated, but not as efficacious as something like methotrexate. So someone said for leflunomide, does it take less time to drop to safe levels after DC than teriflunomide? Well, the leflunomide is getting broken down into teriflunomide, so it actually is going to be probably similar to each other, I would guess. Regardless, I think why you don't see teriflunomide here is because that one has a specific indication for MS. That's why I talked about it there. Yeah, I would imagine it'd be probably similar in terms of getting levels down. But yeah, that was a concern for those patients as well, right? Okay. We talked about sulfasalazine previously. Remember, this gets broken down into sulfapyridine and 5-ASA. The 5-ASA is what's helpful here for our inflammation. That's done by the colonic bacteria. They'll break that down to the active components there. Other things it may do, some thoughts, include things like maybe inhibiting TNF, maybe having some free radical scavenging effects. All of that, you can see within 1 to 4 months or so in terms of response. So relatively quick, like you would see with something like methotrexate or leflunomide for sure. However, a lot of patients will end up having to discontinue this in order to, because of the side effects you're going to see here. So a lot of, cases of nausea vomiting associated with this. You can see increases in LFTs. So that could be a combination there where you'd want to be careful. Say, for instance, you mixed methotrexate plus sulfasalazine, you could see some synergism there in terms of causing hepatotoxicity, right? So you definitely want to monitor for that. Overall, though, again, this is a kind of a long game we're playing here, so you can start low and titrate slowly as needed for these patients here. And again, treat supportively for what they're having. If they're having issues of, obviously you can't really do anything for alopecia, but if they're having nausea, vomiting, diarrhea, maybe eating with meals might help some of them, things like that. The thrombocytopenia, leukopenia is relatively rare with this one, so it could be good from that standpoint. But do be careful in terms of drug interactions. Again, you can see issues in terms of like iron supplements or binding up with antibiotics, so it can be some drug interactions that happen in the GI tract. As you recall as well, it will also turn your urine and stools yellow-orangish sort of color, so that would be also something you want to warn patients about. Again, it can be distressing if they don't know about it beforehand. All of a sudden their poop comes out orange. They might think they're having a GI bleed or something, right? Someone was saying, if someone had RA with a history of renal issues, would you choose leflunomide since it's equally effective as methotrexate, or still prefer hydroxychloroquine or methotrexate as first line? I'd probably go something like leflunomide, just because you can try to dose around the renal dysfunction with methotrexate, but it'd be something I'd want to really be I'd want to watch pretty closely, because it would be very easy for something to happen, like say a patient gets sick and they get dehydrated, all of a sudden their methotrexate levels skyrocket because they can't clear it anymore. I would be much more hesitant in that sort of situation there, but it could depend, are they on dialysis or not? Different things like that could factor into it for sure. But methotrexate levels are something you definitely want to be monitoring with those patients. Try not to cough right in you guys' ears. So kind of bridging the gap between the traditionals to the biologics, I just kind of slapped tofacitinib in here. It's not really a biologic agent, so to speak, but it works as a JAK inhibitor. And so basically you can see here the protein kinase receptors. Remember those ones that kind of dimerize together and then cause all kinds of downstream cell signaling. In this case here, this is going to be stimulating reproduction of those inflammatory cytokines and inflammatory cells, I should say. And so overall, these are going to be actually working to activate these STAT proteins, and these help to cause a lot of these inflammatory genes to start to be transcribed, basically, right? They're stimulating production of these new proteins and cytokines and stimulating cell growth and all of that, right? You can see interleukin-2 or interferon binding to these and causing activation. So by giving the drug, we can basically disrupt this cell signaling process and prevent that transcription from happening in the first place. So novel mechanism, relatively new in the grand scheme of things, even compared to our monoclonal antibodies. So pretty cool. We have the new whole class of drugs here. And again, it's very specific by working on just these JAK proteins as opposed to being much more broad spectrum like methotrexate and affecting all of your immune cells, for instance. Someone said, what antibiotic interactions with sulfasalazine? Basically, you could have issues of binding of the antibiotic. So like maybe a fluoroquinolone might not work as effectively because it doesn't get absorbed as well. So that's what that's referring to. Someone say, this may be a silly question, but just out of curiosity, what about mechanism of action of hydroxychloroquine made people believe it could be beneficial for COVID? I don't know the genesis of that necessarily. We do know that there's a pretty heavy inflammatory response that you do see with COVID. Like we see that in kids especially. But I don't know necessarily. There's probably maybe an animal model that suggested there might be help. I don't know. Everything as far as I know has not been beneficial in humans. But yeah, I don't know off the top of my head. I'm sure we could look it up though. I'm just not going to do it right now because we got other drugs to talk about. The other benefit to tofacitinib is the fact that it's available orally. So all of the traditional ones we've looked at have been available orally. This is as well. All of the biologic DMARDs we're going to look at have to be injected or infused IV. So that's one benefit of this class here is from a compliance standpoint. Xeljanz is typically either used as monotherapy for more moderate to severe RA or in combination with other DMARDs. This is going to be the first case here where you do not want to use a class of drugs along with the biologics. So no tofacitinib with the biologics. The immunosuppression is going to be too great there. I could use this plus methotrexate, for instance. The tofacitinib plus methotrexate would be reasonable, but I would not want to use tofacitinib with something like infliximab, as we'll see in just a little bit. Be aware if you do want to watch for renal hepatic dysfunction, make sure we can reduce our doses in response to that. Or if a patient has a CYP3A4 inhibitor on board, that this can be affected. Levels would rise of this, so you would want to be watchful for that, and you can adjust the dose if they do happen to be on a CYP3A4 inhibitor. Definitely want to check for TB as well to make sure they don't have a latent TB infection. And of course, in terms of risk, because every drug has risk, serious infections, which makes sense based on the mechanism. And there is some small risk for other malignancies that they would be worried about. So things like lymphomas have been shown. But again, it's a risk versus benefit sort of deal here when looking at that. Relatively low, but not high enough of a risk to remove it from the market completely, right? Someone said, so this is an interesting question. So someone said, is it possible to treat alopecia from sulfasalazine with Rogaine or Kinalog injections? So the question there is, why are these people losing their hair? And so in this case here, if you're arresting the reproduction of hair cells, so something like cancer drugs, that wouldn't really help because Rogaine's more of a vasodilator that would just kind of get more blood flow coming to the area, bring oxygen and nutrients and things like that. With sulfasalazine, I don't know of any cases where this is going to be Rogaine would necessarily be useful. In terms of Kinalog, I'm not really sure in that case there because, again, the issue is not inflammation against those replicating hair cells. So I don't know if that would help either, but I'd have to do a search on that. I probably do need to start doing some research into treatments for alopecia at this rate, but I've not done so yet, so maybe one day. Some said, are most of these non-biologic DMARDs acting on the DNA creation, DNA transcription? Most of them are. So methotrexate, sulfasalazine to a degree, leflunomide, those are working on the reproduction of the DNA itself, right? So they're inhibiting production of those nucleotides. In this case here, with something like hydroxychloroquine, that would not be the case. It's more acting on the inflammatory cells and preventing them from getting to the site of action. So depends on which drug you're talking about. See, Isabel is saying Kinalog injections won't improve scarring alopecia. Not sure what kind of alopecia these medications cause. Yeah, I've not gotten a ton into that. I've done a ton of research into alopecia and all of that, so I'm not sure. I'm sure my derm brethren would be able to tell me a lot more information. My favorite derm PAs out there. Okay, so now switching gears and going into the biologics. We call these biologics because, again, most of the time they're going to be actual antibodies or protein-based drugs, biological in origin. So maybe this is like getting like organic produce or something like that. These are biologic. But anyway, so again, we've engineered these antibodies. Again, the proteins that we're utilizing might be human, or it could be partially of another variety. Typically, murine protein is most common, so mouse protein. So sometimes by giving something that is chimeric or predominantly composed of murine protein, remember a side effect could be that the patient has a predilection for cheese. It just happens sometimes, but I'm just kidding. That doesn't really happen. Anyway, so our biologic agents are relatively new in the grand scheme of things as compared to something like methotrexate, but very effective. And they're good if patients have maybe failed non-biologic DMARDs, or if maybe they couldn't tolerate a traditional DMARD due to like side effects or something like that. The downside of these is that they're very expensive, right? It's very expensive to generate new proteins and to put them into a drug that we can inject into your patients. Benefits though, very little monitoring, no issues in terms of renal dysfunction, hepatic dysfunction. You don't have to worry about it so much because these don't really affect or have negative consequences on those organs, right? Because they're very specific for what they work for in terms of their targets. However, they are immunosuppressive. You do worry about risk for TB, right? So it's known about that. And then in a lot of cases, if patients develop an infection, we do end up discontinuing use of these, right? Because it'll give the patient's immune system time to kind of ramp back up, fight that infection, and then they can go back on this. And again, don't give live vaccines. You can give killed vaccines. You can give inactivated vaccines. Those are fine. They may not be quite as effective, but don't give live vaccines for reasons I've already stated. Okay, so the first group we're going to look at is going to be our TNF alpha inhibitors. All of these under this category is going to have pretty similar side effects and contraindications, but in terms of relative contraindications here, CHF is going to be one that we see more so with like infliximab and then also etanercept. And I'll go into the individual agents here in a moment. And in fact, we've actually seen some cases of CHF exacerbations with patients receiving etanercept. So you do want to be cautious there and probably avoid them altogether if they have more progressive sort of CHF, like class 3 or 4 heart failure there. In some cases, multiple sclerosis can actually, you can induce or exacerbate symptoms. That's more of an acute thing. So some patients may do well with this, some patients may not. Typically, you'll trial it, see if the patients have issues, and then if they do, then you can discontinue use. Overall, in terms of black box warnings, there is some for lymphoproliferative cancer here. But again, relatively small risk, but if they have a family history, maybe it's something you'd use in your decision-making process to say, maybe not this set of drugs here. So the first one we have here is etanercept, and basically by looking at this, you can kind of see what the structure looks like. Again, you're not going to memorize anything about this, but it's going to be binding to and inhibiting that TNF. Remember, if you look back at that picture of all the inflammatory cytokines floating around, TNF was a big one. So by inhibiting that, you disrupt that cell signaling that it would normally do, right? Because once this antibody binds to it, the complement system can come in and get rid of it, and it's gone, right? This is actually kind of neat because it's actually 2 TNF receptors linked together to the FC fragment of an IgG antibody. So it's basically kind of like a decoy. It's like you're trying to get the TNF to bind to it so it doesn't actually bind to the actual targets that it's looking for, which is kind of neat. So things to know about the biologic, you can use a non-biologic plus a biologic together, and that's pretty reasonable. So if someone was on methotrexate for a while, things were going well, but now it's starting to progress with their symptoms, you could add on something like Enbrel to that. Okay, that makes good sense, but don't use 2 biologics together. Don't use Xeljanz plus a biologic. Those are kind of the general rules, and there's a slide on that a little bit later on. Typically, though, due to cost and whatnot, these are going to be second-line agents. If you can get away with the relatively cheap methotrexate and the patient can tolerate the side effects and all that, then that's going to be preferred. This is a good backup just because, again, it's going to be difficult to pay for it in a lot of cases. And, again, insurance companies, if they have something else that they say, well, this is first line, do that first, they're not going to want to pay for this because it's much more expensive. But if you have documentation that says, well, they're on methotrexate, but they failed it or they couldn't tolerate it, then you can usually get like a prior auth or something like that for authorization for the insurance company to pay for these. So that's frequently a barrier. Just to give you an example, it's $15,000 a year, which is not the most expensive med that's out there, but it certainly is not something I would want to have to pay for out of pocket for sure, right? This one is an example of a sub-Q one that patients could do at home. You do want to make sure that they're rotating injection sites, so usually rotating around the abdomen, not doing the same site every single time, because that can lead to some scar tissue forming and things like that, and other injection site reactions. And of course, infection risk is going to be elevated. Infliximab or Remicade, this one I see a lot used, and again, in my purposes, I don't see a lot of rheumatoid arthritis from the adult side, but I do see quite a bit of juvenile idiopathic arthritis, so JIA, or JRA is one I'm used to seeing, so juvenile rheumatoid arthritis. And so basically, we see a lot of those patients come in, that are requiring these monoclonal antibodies. They come into our infusion center to get these. Because this one is a chimeric antibody, and the reason why I can tell that is because it has an X in the middle of it. So X meaning crossing human and murine protein, to get the chimera sort of term there. Most of you I see a decent number of you are fantasy nerds anyway, so I don't have to explain what a chimera is, but mixing animals together basically. And anyway, so it's basically the antibody that's targeted against TNF specifically. So it just binds to it, inactivates it, and it can't then go on and cause inflammation to occur there. So we'll typically, again, use this as relatively second line for most patients there. So if they fail first line DMARDs, or if they need some additional help, these can be added on to that. So for example, you can see it used safely in conjunction with leflunomide for people who couldn't get methotrexate, right? So as someone with renal dysfunction and they couldn't receive methotrexate, they could be on infliximab plus leflunomide, and that would be a good combo there. Okay. Now, one thing you'll notice is because also this has murine protein associated with it. I'm glad all those years of animated video. I'm still waiting for them to pay off for me, but maybe one day. I'm just going to keep increasing my dose, and eventually it'll hopefully pay off. Anyway, so because this is foreign protein that you're injecting into the patients can actually develop immune reactions to that. And this is something you'll see with all the biologics. So you can get your traditional anaphylactic reactions, which I've mentioned before, but you can also have antibodies that just neutralize the drug. So you may find that they can actually end up developing these antibodies. The drug becomes less effective over time because it's being neutralized, basically. By giving other drugs like methotrexate along with this, it can help to prevent the production of those antibodies, basically. So this can actually keep the drug working for longer, which is beneficial. Other big thing with infliximab is a lot of infusion reactions, so we typically pre-medicate with steroids and acetaminophen and things like that, right? Okay, so someone was saying, just to clarify, the TNF alpha inhibitors have a black box warning for causing lymphoproliferative cancer, or are they contraindicated in someone with that cancer? So they increase the risk for someone developing that type of cancer. If they already have it, I probably would still not want to give it to them because you can maybe make it more difficult to treat that, basically. But yeah, so that would be, I would definitely not give it to someone with that type of cancer already. Or if they have like a family history, there's really, strong history of that, then I would probably also shy away from these as well. All right. And the other big thing too with a lot of these is that with the biologics, typically the half-lives are such that you don't have to give them all that often. So I'm not going to ask you dosing intervals specifically, but just to give you an idea, you can get to a point where they're coming in every 2 months or so for infliximab. This one, as an example, they can't inject at home. They have to actually come in and get it infused because of all the injection reactions and the risk for anaphylaxis and whatnot. So that's why we end up having them come in. And it takes like 2 hours even to get it in. They have this kind of whole titration protocol. And remember, how do we manage those injection reactions? I already gave it away. But typically we'll pre-dose them with something like methylprednisolone, Tylenol, Benadryl, and then we'll have orders ready in case they have an anaphylactic reaction or something where we can treat if need be. Someone said, out of curiosity, are biologics expensive worldwide, or is that an American thing? I would imagine it's probably a worldwide sort of thing, just because the process for developing it is expensive. However, like insulin's a protein, but you can see that can be inexpensive in other countries versus here. So some of that might be it depends sort of thing. One thing you'll see that comes up occasionally is something called biosimilars, which is kind of interesting. So you don't have like traditional generic versions of these antibodies because they're kind of treated a little differently because they're proteins and they're kind of I don't know, there's a lot that goes into it, but basically, instead of having a traditional generic, like generic versus brand methotrexate, you would have what they call a biosimilar product that would be equivalent to a generic. And so some people have concerns about the efficacy of those, but they have to go through the FDA to get approved and all of that. But there may be questions of like, okay, well, if I can get a cheaper biosimilar, is that going to work the same as the actual real deal infliximab would? And so that might be something that comes up in the future for you guys. So I'm saying, so methotrexate acts both to help RA and secondarily through immunosuppression prevent the body from reacting to Remicade. Yes, that's actually true. So it would both treat the RA and then also keep the Remicade working for longer, basically. So very astute observation there. Okay. Going along the same line here of adalimumab or Humira, this is another one that comes as a pen. So I see a lot of patients, a lot of our, especially like our GI docs and rheumatologists like to start patients on this because it comes as a pen. So that way those patients don't have to come into the infusion center every couple of weeks. And so I see this used pretty frequently for them. It's also all human protein. So it's a humanized protein. You can see that with the U right in the middle. I don't expect you to remember if it's a chimeric protein or humanized protein, but just know that that's some of the thought process that goes into these things of why we may pre-medicate a patient getting infliximab with methylprednisolone, but we don't for this one. We don't need to because they don't get as many infusion reactions because the protein looks more human than it does, say, something like mouse protein, right? And isn't that wild? Like we inject people with mouse protein. Weird to think about sometimes, but anyway. So less risk for allergy, which is fantastic. And again, use second line, potentially added on to people taking traditional DMARD sorts of therapy, right? Again, given every other week, so good long half-life, so that does help out with compliance in a lot of cases. Notice very similar in terms of adverse reactions, so I don't have to really belabor those points much more. They kind of fit this to the whole class, basically. Now, abatacept is a little bit different. This is more so for probably like, if most patients would probably start out on something like methotrexate, they fail that, they probably go to a biologic DMARD like something like, infliximab or Humira, for instance. These other ones here might be kind of down the line from that, even. So if they couldn't get infliximab for whatever reason or they had a bad reaction to it, they could try something with a different mechanism, basically. So those are all the TNF alpha inhibitors. Now we're getting to a few different mechanisms here. So this, for instance, is called a co-stimulation modulator. So basically you have the CD protein, CD80, CD86, and they work to help out with like these antigen presenting cells. So by giving an antibody to try to prevent that signaling from happening, you inhibit the inflammation. So just a different way to do it. Again, you'd see this either by itself or in combination with a traditional DMARD. But for instance here, if patients have failed a TNF alpha blocker, this might be the next thing you use, right? You may find some activity here. Again, in terms of adverse reactions, pretty similar to what we saw with all the other monoclonal antibodies. Someone says Humira, cheaper because it's human protein. I don't know that off the top of my head. That's interesting though, but I just got a picture in my mind of like a human farm or something. We're just like shaving off pieces of protein, like a deli or something, and that being cheaper than like the mouse side of the factory, I guess. But I do not know that off the top of my head. I'd have to look that up. Interesting question though. You guys keep me thinking during these lectures, which is good. I appreciate that. That does sound like a horror movie. That would be not a very great way to make drugs. We used to, when you think about like products coming from animals, like we'll talk about this in endocrinology, but we have, we used to get insulin from actual cows and pigs. So you actually have like bovine insulin and porcine insulin. The new steam, I don't know about that. I'm not a very good writer. But there's been a history of using animal-based proteins, but a lot of this is recombinant stuff, right? So when saying like human versus mouse protein is not necessarily the actual animal itself has donated that protein to us, but it's more so that we're using the actual amino acid sequence from that protein, right? Or from that animal, basically. So in that case there, I can't imagine that the production would be much different, but who knows? Who could say? Probably a drug manufacturer, but not me. Anyway, rituximab is an interesting one. We talked about this before, I think, briefly when talking about, I believe it was in the cancer talk. This actually works for to bind to the CD20 protein on the B lymphocytes, and again, helping to disrupt the cell signaling to decrease inflammation. This would be another case where you use if patients had failed methotrexate and TNF. This one like has to be pretreated. I see a ton of infusion reactions related to rituximab. Sometimes it has to be given like over 4 hours in some cases because patients get so sensitive to the reaction when they're infusing it. And again, just because a patient is getting the infusion and they get a little hypotensive, a little itchy or something, it doesn't mean it's like a full-on anaphylactic reaction. You can treat through that in a lot of cases there. It's only would be if we had something like airway compromise or if they're cardiovascular compromise, we start to really like bust out the epi and all of that, right? So another one here, I actually see this used quite frequently for a lot of our JRA patients. They have tocilizumab. That's how I pronounce it at least, or Actemra. Again, most of the time the brand names are just easier to say. But this one's actually going to be against IL-6. So again, if they failed a TNF alpha inhibitor, we could utilize a different mechanism. So this would be one of those ways. Is instead of going after TNF, we're going to go after IL-6 instead. Pretty well tolerated. Against another one I see patients have to come into the infusion center for, so they're not taking it by themselves at home or anything like that. This one's interesting though that it does induce CYP3A4, so you can actually cause increased metabolism and lower levels of drugs that are affected by that. So for instance, say you had a patient who's on methotrexate, so you have like juvenile rheumatoid arthritis patients, like 16, female, who was on birth control and on methotrexate and tocilizumab. You can see that interaction would happen there to where she could potentially get pregnant because you'd induce the metabolism of the birth control, half-life shorter, doesn't prevent ovulation, and she gets pregnant, right? We'll talk about OB-GYN stuff later on, but this is how you can see these interactions happen here because you're like, well, who in the heck would ever get pregnant while taking these drugs here? But, it happens so all the time. Hopefully not all the time, but it happens. But anyway, other drugs like this would be effective: statins, warfarin, etc. Right? It's kind of interesting. It has a reaction of GI perforation. I've never personally seen this, but it is at least reported, so it's interesting to note. So with these, they're not perfect. Like they work pretty well for a lot of people, but maybe about 30% of people do develop failure. And you can either have that happening early on, so like a primary lack of efficacy where patients are on it for a 3 or 6 month trial and they don't have any response to it, or oftentimes they'll have that secondary lack of efficacy where either the disease is progressing or we get to the point where the body is now developing antibodies against that biologic agent and neutralizing it. So that's why we end up having failure of therapy after the fact. Isabel's saying, I thought warfarin was metabolized by CYP2C9, not 3A4. You're half correct in that. It is metabolized by 2C9. 2C19 is also involved, and to a lighter degree 3A4. 3A4 is not the predominant enzyme to metabolize warfarin, but it is a contributor. So again, keep in mind it's not just like one CYP enzyme per drug. It could be multiples that metabolize a given drug there. So the body's complicated, unfortunately. Some says rituximab also an IL-6 antagonist. No, it is not. It is actually going to be against CD20. So again, different mechanism than the TNF inhibitors, different mechanism than Actemra. Okay. So in this case here, you may either need to add on like a non-biologic. So if they were only taking like infliximab by itself, but they failed that, you could add on a non-biologic. That can be helpful. Or switch to a different mechanism. So maybe if they fail infliximab, go to Actemra, for instance. Okay. Remember, do not combine two biologic agents together. Don't combine a biologic plus Xeljanz. Again, Xeljanz is a relatively new class, so again, when you introduce this is going to be probably up to the provider in deciding, it may not be as set in stone as using some of these older agents here. Someone says rituximab IL-6 inhibitor or TNF alpha. Yeah, so that's CD20. That's the one that's inhibiting there. So that specific CD20 on those immune cells. Okay, so corticosteroids are also going to be basically used probably for most of these patients here. You may either find you can use them for sort of like flare-ups that happen, or in some cases you use them for kind of like daily use, right, to help prevent symptoms. Ideally, you'd want them off of corticosteroids, but some people, they're just going to require low-dose steroids all the time, right? We know a lot about corticosteroids. We know they're anti-inflammatory. We know they're immunosuppressive. We know all kinds of side effects they're going to have. So, we know a lot about these already. So just talking about them in terms of utility in RA is how I want to mainly focus on this. You can see that again, chronic therapy, a lot of patients are going to require this. You can try to do like every other day therapy, but it tends to not be as effective there. So some people just be on a dose every single day. So prednisone, 10 milligrams daily, every single day. Oh, did I have slide 22? Let me check that out. Do I have an error on my slide? Oh my goodness. Oh, look at that. That is wrong. I apologize. Again, PoBuddy is perfect, and I am fallible. There we go. How about that? You guys can do the same. Update to your slide. I apologize. One of the students during the interview today said, I asked them a question. They said, that's a good question. I said, that's the only kind I ask. Did not get the joke. I had to inform them of that. Anyway, so we mentioned that it may just be on chronic therapy. My slide. Oh shoot, sorry. Okay, so I updated the slide 22. Oh my goodness. This is the problem. I interview all day long and I get kind of tired and some little mushy mouth. Here we go. Okay, so here's the correction I made. I'll even make a different color. Show you guys. Oh, that's a bad combo. Anyway, so moving forward. So the other thing we could do with this therapy here is you could also do what we call bridge therapy, where basically you're kind of bridging a period of time where maybe the patient's starting a new medication, for instance, and you're waiting for it to become effective. So say, for instance, someone gets diagnosed with RA, they have all the classic symptoms, starting them on methotrexate. Methotrexate may not kick in until like a month or two down the road. So I want to treat them now. So you may bridge them with some corticosteroids. One way to do it. In some cases, you may do it for disease flare-up, so they have an acute exacerbation. You can do it that way. And then in some cases, we may also do intramuscular administration. So we can do that sometimes for like burst therapy, where they're having one of those flare-ups. Or in some cases, we may do it for long-acting formulations, right? Or long-acting forms. So if you ever see like a depot Medrol, that's what we're talking about there. It's a depot form of the drug. It stays in the muscle for a long time, slowly leaching out the drug into the bloodstream. Just like the Home Depot holds a bunch of stuff. Depot of drug in the muscle can do the same thing and slowly let it out. The nice thing with that too is that the level will have a natural taper to it, so it kind of builds in its own withdrawal protocol by slowly reducing those levels, giving the chance for the adrenal glands to kind of pick back up when they are starting coming off of it. Or if they, for instance, miss an appointment or something, they're not going to go into adrenal insufficiency because they are missing their dose, for instance. Occasionally, you can do intra-articular injections there. This is good for if they only have like a couple of joints that are being affected. It's also going to be acting very locally, so limited systemic involvement. So that can help to limit some of the side effects you'll see there. However, you don't want to do it too often. So they kind of limit it to like 2 or 3 times a year because you can see issues like tendon atrophy and increased joint destruction by having too much corticosteroid action there in the joint itself. So you can get too much of a good thing, so to speak. So someone's asking, does the order matter when progressing to a new drug if a patient fails the one they're on? For example, after failing a TNF inhibitor, do they need to try CD20 then IL-6, or can it be done either way? Yeah, so I'd probably say start with a TNF inhibitor, and then if they don't tolerate that, it's kind of dealer's choice at that point. So for instance, I see a lot of our rheumatologists for our kids will switch them from something like, Humira. If that's not working, they'll switch them over to Actemra. I see a lot of Actemra being used in that patient population, but it may be dependent on insurance coverage, could be dependent on the provider and what they prefer, things like that. So that's what I would say. It's kind of dealer's choice at that point. So if I had like a test question, I said this patient's on methotrexate and infliximab and they fail, what would be the next most appropriate drug to use? I wouldn't have you pitting rituximab versus Actemra because you don't really have enough information to make that decision between the two. Either of those would work. However, if I put, they failed infliximab and gave you an option of Humira, you wouldn't want to do that because you wouldn't want to go from a TNF inhibitor to another TNF inhibitor. You want to switch up the mechanism. So just one thing to consider there. Someone said, just to confirm, Xeljanz is a non-biologic DMARD, but you still check for TB like you do with biologic DMARDs. That is correct. Because it does still have some pretty decent immunosuppressive activity, so you do definitely want to check for that. Okay, so when using corticosteroids, you want to use the lowest dose possible, as we know, and we do know that it does help over the long term. You can decrease some, at least radiographic progression of disease, and it helps out with the symptoms for sure. And again, if people are going to require it long term, then that is what it is. But we do know to watch out for those side effects. So we know it's going to suppress HPA axis. So if they're taking like oral daily doses of these drugs, like don't stop them cold turkey. We do know watch out for things like osteoporosis. We do know that it can worsen that, especially if we're having older females starting this. We do know that's a risk. Older guys too, but we typically think females for that. Cataract, hirsutism, hyperglycemia, all these things, and especially it just gets complicated with old age, and all these things may be happening anyway. This could be accelerated. So again, we know this stuff. We've covered these quite a bit already. Now, NSAIDs, we've talked about NSAIDs as well. These are also going to be used for symptomatic management for these patients. Additionally, recall, if you will, that there are two varieties of cyclooxygenase. There's COX-1 and COX-2. COX-2 is going to be what we call the inducible form of cyclooxygenase. COX-1 is the constitutive form. COX-1 is really important for producing that protective barrier around the stomach, preventing it from digesting itself. COX-2 gets ramped up when inflammation's happening. So these patients are going to really be producing a lot of COX-2, and that's what we want to inhibit. We're going to see, though, that, we know that things like peptic ulcer disease is commonly caused by NSAIDs. We're going to see that, okay, well, if we can just focus on COX-2, obviously that would solve our problem. We still have COX-1 active. That can still help to protect the stomach, but we're going to see there's going to be some downsides to that in just a little bit. Basically, though, and I think the next section we go into is the ortho. So I think I talked more about the NSAIDs there and specifics. But basically, and we'll get into the differentiating between COX-1 and COX-2 inhibitors in the ortho section. That's coming up next. But I'll just kind of give you two briefly here. Normally, I do that section before this one, so that's why it looks a little out of order. But basically, you're going to find that NSAIDs are going to be useful for RA. Most patients are going to be on some kind of NSAID for life, probably. And then for OA, this is going to be a useful adjunct. So it can be useful as an add-on for osteoarthritis if used by itself even. But we're going to see that these do nothing for disease progression. Okay, these are only for symptomatic management. So if they're really not having a lot of symptoms, they may not have... Oh, sorry. Wait, I think Kyle, you're a little late there. Yeah, so I went ahead and showed you guys the correction I made on that. Wait, it was actually from a few minutes ago. Never mind. Lost on the chat. Anyway. So I guess I'm behind. But anyway, so looking at this, you're going to see that some patients respond differently to different classes of NSAIDs. We're going to find that, if someone doesn't respond well to ibuprofen, it doesn't mean they're not going to respond well to all NSAIDs. You may just need to switch it up a little bit and try a different variety, which I'll talk more at length about, and I think in an upcoming section there. Basically, though, what we're going to see, though, is that by targeting COX-2, you're able to affect the cyclooxygenase that's more important for inflammation and spare COX-1. We'll find that if you just entirely focus a drug just on COX-2, that actually leads to increased risk of heart attack and death. And we had a few drugs that did that. And so, Vioxx was old news when I got into school, but some of you may have heard of it before. But it was a really classic case of a drug that came out that looked like a wonder drug. It was going to be like a huge blockbuster drug. Because it was able to target COX-2 exclusively, inhibit all this inflammation. It was great because it didn't hit the stomach at all. It didn't affect COX-1, so the stomach was good. However, once they started giving it to all these people, they realized that, okay, wow, there's an increased risk of death associated with this, and it got pulled from the market. So we still have like two or three drugs that still have some partial selection for COX-2. So we'll get into that in the next section, but we'll talk about like celecoxib or Celebrex, talk about meloxicam or Mobic. Those have some degree of COX-2 selectivity, but not so much that you see the increased risk of death. Okay, so we have some relative COX-2 inhibitors, but those are going to be better for patients that have a history of like peptic ulcer disease or NSAID-induced ulcers. That's going to be preferred for them. Okay, so if they have a low risk for GI complications, then any NSAID's going to do. You're fine to pick whichever one you want. If they have a high risk for GI complications, you can either select a COX-2 selective agent like celecoxib or meloxicam. Those will come up in the next section, so I'll talk more about that there. Or you could use an NSAID plus a gastroprotective agent. So we could either use a PPI or misoprostol could be used as an example there. Okay. For patients with high-risk cardiovascular disease, maybe like a history of MI, things like that, I would say just use a non-selective NSAID and you're going to be good. That same risk for increased death was only associated with the pure COX-2 inhibitors. So in this case here, if I had someone with a history of cardiovascular disease, using an NSAID is going to be fine. That's non-selective. Yeah. Anyway, so how do we kind of go through this process here? So we can basically see if you have like a DMARD naive patient, they're like, what's a DMARD? And you can educate them. I'm just kidding. That doesn't mean, basically they've never been on a DMARD before. But let's say they have low to high disease activity. So again, typically starting them off on a DMARD plus or minus prednisone, right? So the prednisone is being used there as a bridge therapy until they get the inflammation under control. Methotrexate probably going to be used for the most part for most patients. At that point, then you can either consider using combination DMARD therapy or use something like a TNF alpha inhibitor plus or minus methotrexate, right? So again, I want you to think about sort of like the stepwise approach. And notice here in this algorithm, they even put tofacitinib as one of the kind of second lines after methotrexate's kind of failed on its own, right? So you have a lot of options that you could do here. So I'd probably either say start them off on a TNF and alpha inhibitor, or maybe tofacitinib, right? And then plus or minus methotrexate for all of those. If they're getting some benefit from methotrexate before, then add it on. You know, if it was they can't get methotrexate because of liver dysfunction or something, then just go ahead to use one of these by themselves, okay? So then at this point, if they have a single TNF alpha failure, you can try maybe a non-TNF alpha inhibiting biologic agent. So maybe switching to like tocilizumab or something. Typically, I would not want to put them on like another TNF alpha inhibitor. It wouldn't really make a lot of sense in that case there. And then remember, tofacitinib is also another option at that point there. If they had a non-TNF biologic failure, so maybe they're on like leflunomide or something, then I'd maybe add on probably at some point consider adding on a biologic agent at that point. So that's kind of the stepwise approach I would take. So if I had a test question that said, you know, patient just now diagnosed with rheumatoid arthritis, you're going to start them on prednisone, and what other drug would be most appropriate first line? And probably say methotrexate, right? That'd be the one to go with. However, if I said, oh, they have a history of alcoholism and hepatic dysfunction, you know, so that would preclude you from using methotrexate right off the bat. So you could say something like, well, maybe I'll use like leflunomide, or maybe I'll use something else. So you can consider another non-biologic at that point. Or, you know, maybe just go with the biologic. So you have a lot of options that are there. So I want you to kind of think about things like, if I write a test question, it'll probably be something to do with like a contraindication, or maybe like a drug interaction or something like that. So those are the things you want to think about when you have a lot of options. What are the things that will lead you to choose one versus the other? And frequently it's the patient themselves, something in their history or something like a comorbid condition or another drug they're on that will make that difference in those cases where you have a lot of options. Okay. So there you go. Trying to give you more examples of test questions. Looking at combination therapy, again, using two non-biologics is fine, right? You probably don't want to use a history of methotrexate and leflunomide together. They do increase that risk of hepatotoxicity, so that'd be one thing you'd want to watch out for. But, you know, something like hydroxychloroquine and methotrexate, totally good, right? In terms of traditionals plus biologics, again, really any of these would be fine to use here. Anakinra I didn't really talk about, but that's another mechanism. Don't worry about that one there. But really using any of the traditional DMARDs plus a biologic, you're going to be okay there, right? But just don't mix tofacitinib plus a biologic or two biologics together. That's a general rule of thumb there. Okay, so switching gears a little bit, talking about some other drugs. So acetaminophen, you know, we didn't really talk about it at all for RA because it's really not all that effective. Because if you recall, the main distinction between like an NSAID and an acetaminophen is in terms of their actions is that acetaminophen doesn't really have any anti-inflammatory activity. Also, it's pretty well tolerated. So this is why we like to use it first line for things like osteoarthritis, because it lacks a lot of the issues in terms of like renal toxicity or you know, bleeding risk or things like you know, GI risk that you see with the NSAID. So for those patients with OA, if you can start them off on Tylenol first, that's always going to be a good first step. Is that going to work for all of them? Questionable. Who knows, right? A lot of patients are going to fail that, but that's why we at least start with it. And typically we'll have them do scheduled therapy. We're going to talk about pain management a lot more coming up, but basically you want to make sure that patients are going to have something to cover basal pain, so pain they're experiencing 24/7, and then we'll talk about things that we can do in order to treat breakthrough pain. So that's usually where you get some as-needed medications involved there. Basically, with this one, you know, with acetaminophen, relatively safe, but make sure they're not going to be dosing above the recommended maximum. So 4 grams is typically what I think about as being the easy to remember maximum. Don't have them take anything with acetaminophen in it above that, because the risk for hepatic toxicity is relatively high. Again, in terms of like toxicology, I've probably seen just as many cases of people accidentally giving themselves Tylenol poisoning as I have people who have intentionally done it themselves. Okay. This one's just a little more insidious because they're doing it over the course of maybe weeks to months. Warfarin, obviously, you know, if they have patients with hepatic dysfunction due to acetaminophen, that's going to make warfarin work even better. So bleeding risk is going to be elevated there. Someone says, let's see. Okay, so someone said, can you please go over the second step of treatment after methotrexate and prednisone in that flow chart? Yeah, sure. I can definitely do that. So basically here you have a lot of options in terms of what you can do at this point here. So you could use a combination of DMARD. So that means you could use something like methotrexate plus sulfasalazine or hydroxychloroquine or something like that. Or you could utilize something like TNF alpha inhibitor, so infliximab plus or minus methotrexate, or use a non-biologic plus or minus methotrexate there. So, you know, tofacitinib can fit into this category. Methotrexate plus hydroxychloroquine, all of those are going to be fine at that point there. Again, this plus or minus means you could use as monotherapy, right? So if someone failed methotrexate, then you could utilize maybe Xeljanz by itself, and that may be good for the patient. It's hard to, you know, just to see how they respond to it. But if they had good response to methotrexate initially, but they're not maybe at their goal in terms of symptom control, then that's where I'd probably add on the second agent. If they failed methotrexate because renal dysfunction, hepatic dysfunction, etc., then I'd just probably go with one of these as monotherapy and see how it goes. So that's kind of the general rule of thumb. But let me know if that does not make sense. Someone said, if a patient was alcoholic or had a history of alcoholism, would you not recommend acetaminophen for the OA? So I would be more cautious. There's recommendations in terms if they have a history of alcoholism, because alcohol does increase your risk for hepatic injury due to acetaminophen. What I would say is reduce that maximum, and I think like 3,250 milligrams or 3,250 milligrams is their max if they have a history of hepatic dysfunction. But obviously you'd want to see where they're at currently and make sure they're not already elevated, because if they're sitting there with their LFTs, you know, have an AST ALT of like, you know, 200 or 300, I probably would not want any acetaminophen coming into that patient. But yeah, I would be much more hesitant in that sort of situation. All right. So anyway, so good for OA, but probably not going to be very useful for RA patients for acetaminophen. Now, topical analgesics here, we do have some topical NSAIDs, and this can be beneficial for patients have limited number of joints that are being affected here. So you'll see this a lot for like osteoarthritis of the knee, especially if it's just the knee that's being affected there. We have a few options. We have things like diclofenac or Voltaren gel, which is now within the past couple of years made over the counter. And then something like a salicylate-based creams like Aspercream can be used there. This is beneficial if you had someone like maybe like a high-risk, say GI history, and they only had a few joints being affected. This may be beneficial because it has very limited systemic effects, would not be really affecting the stomach there. So it could be pretty good as an alternative. In terms of compliance, though, you know, patients may not want to put a cream on, and they need to be consistent with using it. Otherwise, it's not really going to be that effective. So, not as easy as popping a pill, but also not you avoid a lot of the side effects. Capsaicin is also an option. This is pretty interesting. Utilizing capsaicin as a means of pain management is kind of counterintuitive, you'd think, because they're like, well, if I eat a spicy pepper, that hurts. Like, why would I want to do that to treat pain? Basically what it's doing is it causes your nociceptive fibers to release substance P, which sensitizes the fibers and cause more painful signals to be sent up to the brain. It says, ow, that hurts, right? So basically what this does is that by constantly applying this capsaicin cream to, say, the joint that's affected, you deplete substance P, and that way it's no longer available to sensitize those painful fibers. So it overall will hurt at first, it'll be uncomfortable at first, and then as they deplete substance P over the course of several days to weeks, it will then improve and their pain should be better. So it actually works pretty well for people who can be consistent with it. It's just a matter of like, initially it's going to kind of burn a little bit, not feel great, and then patients sticking with it, because if they stop, then they start to make more of that substance P, and then they're back in the same boat they used to be. The other big thing too, the capsaicin, you know, same thing that makes jalapeno spicy, another pepper spicy, is that you don't want this to come into contact with any mucous membranes. So, and I know I do this, I'm not sure if you do, but every time I ever chop up a jalapeno, I instinctively have to scratch my eye for whatever reason. Even though I say, don't scratch your eye, I always end up scratching my eye no matter what, and pain ensues. So it's important to make sure patients are either wearing gloves when they're applying this, or make sure that they are washing their hands, but with soap and water. The soap is the important bit because capsaicin is pretty lipophilic. And so if you just use water, it's just going to stick right there on the hands and it's not going to do anything. You need to use soap and water in order to get rid of that. That's why they tell you if you're eating something spicy, utilize milk, because milk is full fat milk, at least, because milk has that fat's lipophilic and it'll grab that capsaicin up. Husband notorious for rubbing his eyes after handling peppers. Yep, exactly. And interesting, I had a call one time at the Poison Center. This is back in my fellowship training, where I had a young lady who called up and she had had some peppers or something like that, and I think she like rubbed her thighs or something, and I guess she had shorts on or something. Rubbed her thighs, and her thighs were just like on fire. It hurt so bad. And she was just calling, like crying. It was so bad. And she was just like, what do I do? What do I do? And I was like, okay, well, do you have any milk in the house? She's like, no milk. And I was like, well, do you have like any olive oil? And she's like, I do have olive oil. I said, okay, rub that in her thighs. And she's like, excuse me, where did I just call? And I said, no, trust me. So anyway, she did it. I called her back a couple minutes later, and she was actually feeling much better because basically the oil or the fats will pick up that capsaicin and get it off of the skin, basically. And she ended up appreciating the advice. So anywho, so pretty handy, but a lot of people will not stick with it. So ultimately, compliance is going to be the major determinant of its efficacy. We also have some other things like counter irritants, which basically kind of like draw out the pain, so to speak. So like menthol, camphor, things like that is sort of the oil of wintergreen, these kind of products there. Most of them are over the counter, they work reasonably well. It just depends if the patient is going to be compliant with it, because again, it may be uncomfortable for them when putting that to the skin. So anyway, we could also utilize intra-articular corticosteroids for things like knee and hip osteoarthritis. I always love when I get those spoonerisms. But anyway, so if you had patients with OA, and again, limited number of joints that are uncontrolled just with NSAIDs and APAP, you can utilize, I just snorted your water there. Anyway, so again, don't do this more than every 2 to 3 times a year, because again, you worry about joint destruction in overall further damaging of the joints. Really, and really the big thing for these patients is hip and knee replacements. Right, it's going to be the best thing. Can't really get a hand replacement, but replace the joints, and that will deal with the pain most effectively. But some patients can't do that. Opioids should really be utilized for very short-term therapy, as little use as possible, only in the most necessary of cases. And again, there's not really a lot of evidence to show the long-term efficacy and actual better outcomes of patients on opioids long-term. Because remember, I don't care about necessarily what the pain score is. I wonder what the function of the patient is. Can they get up, walk around, do the things they want to do? Can they go to their job, etc.? If they're on opioids and they are not gaining function or losing function, then it's not really doing them a whole lot of good. So that's one of the things I'll talk more about when we get into pain management a little bit later on. Now, in terms of like dietary supplements, one thing you may want to consider is glucosamine and chondroitin. Keep in mind, whenever you're dealing with dietary supplements, is that they're not regulated by the FDA, meaning that there's no standards in terms of ensuring that every batch you get of that product is going to be the same as the next one, okay? So even though they say it has this much glucosamine in it, that is not verified by the FDA, right? As opposed to you would see with acetaminophen, right? So that being said, I do think there can be some benefit to using these products here, but I like to make sure that patients are using consistency in terms of what brands they're picking, and maybe picking a little more reputable brands. So I don't know, I don't have any specific to mention because none of them are sponsoring me. But I wouldn't pick the bottom of the barrel stuff, because there's no guarantee that what they say is on the bottle is actually in those capsules that they're taking there. But anyway, glucosamine and chondroitin are actually found in cartilage and synovial fluid, so it's a very natural sort of product there. And it's thought that they can help to increase articular cartilage production and maybe help with preventing the breakdown of the cartilage that's already there. So it's trying to slow down the progression of disease to a bit, to some degree. And they've seen some moderate effects out there. And so there's even one case where they actually showed some decent benefits to utilizing glucosamine specifically. But again, your mileage may vary with your patient, so it's something to recommend. And again, ask them, are they taking it? Because they may not mention it in their medication list, since it is an herbal supplement. but relatively safe, pretty well tolerated. So there's really no downside to using it for the most part. However, just be aware of the fact that patients with a shellfish allergy can have a response to this. So you would want to be careful. That I believe it's the chondroitin aspect of it may have a cross-reactivity with some shellfish allergies. So, but I'd have to double check that one. I always forget that one. In other cases here, we can utilize hyaluronate injections. So this is actually something you would do for OA specifically, where you could utilize intraarticular injections. And basically it helps out in terms of anti-inflammatory, having some anti-inflammatory properties, and helps to reduce pain, mobility of the knees, especially, it can certainly improve. This is given once every 3 to 5 weeks or so. I know my mom for a long time had pretty bad knee osteoarthritis, and she loved these injections, made her feel pretty good. So, and relatively free of side effects, which is beneficial. No drug interactions or anything like that to note. So, let's see, someone question. So why doesn't the FDA regulate vitamins? That's a good question. There is a whole law regarding dietary supplements, but the basically that's just the delineation. So these products, they're regulated heavily on in terms of like what they can say they do. See, Shelby a minute behind, but I think if they're CGMP certified, then you can be pretty confident. Yeah, so there's certain things you could do there in order to make sure that they are a little bit higher standards, but it's still not regulated by the FDA specifically. So that's one of those things that you would be maybe could be looking for to say that's probably a better product than maybe some other ones there. So again, it's a helpful step, but still not directly regulated by the FDA. So what's interesting is like with dietary supplements, they're really what the FDA will come down on them for is if there are safety reports being filed about them, they will come in and then may take some stuff off the market. So for instance, with I know there's been like Oxycut, for instance, had some products where they were causing hepatotoxicity, and so the FDA came in once they heard about it and they took it off the market, right? But there's nothing stopping hydroxycut from just putting a new product out there, right? So the FDA only deals with taking them off. And then the other thing too is the marketing, what they say they can do. So if you look at glucosamine and chondroitin, it won't say treats osteoarthritis because you can't legally say that any dietary supplement treats any condition. But you can say supports good joint health, or like for diabetes stuff, it'll say supports glucose level or glucose homeostasis or something like that, right? So the whole point being is they don't treat anything. They can't say that. Otherwise, the FDA will come in and take them off of the market. So it's kind of interesting from that standpoint. Someone said, I thought you couldn't give injections more than 3 times a year. That was for the corticosteroid injections. The hyaluronate injections, you're okay. You don't have to worry about that. The same issue does not pop up there. Okay. So kind of going through the flow sheet a little bit here, the algorithm. So you have a patient needs, treatment for osteoarthritis. Can they utilize acetaminophen or not? If they have any contraindications, then you want to go towards the topical NSAIDs. Otherwise, if they can get acetaminophen, see if it's effective or not, right? Typically for patients who cannot take acetaminophen, we like to use things like topical NSAIDs or intraarticular corticosteroids. That's more beneficial mainly because it limits the side effects you can see with things like oral NSAIDs taken chronically, right? So oral NSAIDs can be used, but just be cautious and make sure they're aware of the side effects to look for, especially like GI stuff, right? So if they notice any dark tarry stool or hematemesis and things like that. If that's still not working, then you can consider alternative agents. We'll talk about tramadol more in the next PowerPoint, so don't worry about that one. We'll get to it in the next time we meet. But other things you can consider, like opioid analgesics, surgery, other things like that. We'll talk about some of these other options in ortho section coming up in just a little bit. For hand stuff, surgery is not really going to be an option for these patients here. So we're going to be looking more so at utilizing NSAIDs. If they are greater than 75 years of age, we like to utilize more topical products because, again, we worry about things like kidney injury, GI injury, and stuff like that. If they're less than 75, then you probably get away with oral NSAIDs, and that's okay. We'll talk more about their selection in the next section coming up here. And then at that point, if they're still not effective, it's where you start to consider utilizing multiple therapies together, maybe topical NSAIDs plus something like capsaicin or something like tramadol, which we'll talk more about tramadol later. Anyway, so any questions on that section so far? I don't think I have enough time to really finish out most of this. Yeah, I've talked enough. I'm kind of tired, and I'm going to go ahead and I got to save my energy for grading some prescriptions tonight. I'm going to get it done tonight. kids screaming or not, no matter what, I'm doing it. So anyway, so someone had a few questions here. So let's see. So going back to the prescription assignment, someone said when writing a script for something like amoxicillin 400 per 5, is it preferred that we write it as take 400 milligrams by mouth twice daily for 7 days, or would take 5 mLs by mouth twice daily for times 7 days suffice? So when you're doing it with, as I ask, is often mLs is easier for patients to understand. The drug is a liquid supplied to IV orders as well. Okay, so good question. So when dealing with orders like that, if you want to make it as easy for patients as possible, right? So when you say take 400 milligrams, they have to then convert that into how many ever mLs it's going to be. I don't want my patients to have to do the conversions. Make it, I say KISS, keep it simple, students, right? So I go ahead and just say take 5 mLs by mouth twice daily. That's the preferred way to do it, right? You could put the 400 milligrams in parentheses, but I'd say put the ml amount, okay? So on the other hand, though, when you're talking about inpatient orders, like what you're going to be doing for the second assignment here, you're going to find that for IV orders, remember that you have a whole healthcare team helping you out. So for instance, if you were to write an order that says Ativan 2 milligrams IV stat, okay? That's a sufficient order, because when that order gets processed through, it's going to come to the pharmacist. I'm going to look at that order. I'm going to say, okay, 2 milligrams. What do we have that we carry? We carry a 2 milligram per ml concentration. Okay, so 1 ml, right? And so we'll draw that 1 ml up and give it. You know, in some cases, maybe nurses that are interpreting that and then doing the conversion. But from a provider standpoint, you don't really care so much about the concentration. That's more of a logistical thing that we deal with on our end of things. So for those kind of IV orders, just write the milligram amount and we'll figure it out, okay? The one exception to that would be if you're dosing something specifically in mLs. So for instance, if it was like an IV fluid, you dose that in mLs, right? You're not going to say, give this many MEQs of sodium chloride with D5. You're not going to do that. So just say, you know, 125 mLs an hour of D5NS, and that's sufficient. You know, other things that might be dosed in mLs would be, for instance, maybe like a Fleet's enema. See that order pretty commonly. So do 77 mLs or 133 mLs PR once of Fleet's enema, something like that. So that would be how I'd answer that question. Some said, just so I have it right, APAP over NSAIDs. For osteoarthritis, yes. If they can. It may not be sufficient for them, but that's always the first thing you want to go with, because it's, again, relatively safe when taken in correct doses. For RA, acetaminophen has no real role, okay? So someone said the vaccine question was covered in lecture. I think sometimes hard for us to determine what is important to understand and memorize for each drug when there are so many, thank you for emphasizing that, details that go into each one. Yes, that is part of the challenge of my course is, you know, there's a lot of volume of information. Hopefully I try to emphasize things that I say in lecture in such a way that you kind of pick up on that I think this thing is important, you know. If I put every single word that I say onto the slide, you would probably go crazy, right? It also is important skill to learn for you guys in terms of how to deduce what is actually important and what is not so important. Not that I'm trying to give you extraneous information on purpose, but when you're learning things, to be like, okay, what are the things that, like, the things I really need to take away from this? Because one thing I'll run into with students, and again, I'm done, so if you guys want to leave, you're fine. I'm just kind of waxing poetic at this point. But one thing I'll see with some students who struggle in pharmacology is I'll ask them, like, how do they study? And they're like, okay, well, I watch your lectures and I take down every single note you say, and I make flashcards out of everything you say. And basically they're trying to write like a whole pharmacopoeia, like they're writing a whole book. And I'm just like, well, what was like the 5, if you had to like reduce my lecture down to like the top 5 points, what would you remember? And they're like, and they freeze. And I'm just like, just give me 5 points. And they're just, they get paralyzed by all of that information. So part of the process here is to learn, okay, what is the really most important things I need to know from this? And because you can't memorize everything, right? That's just not going to be feasible for a lot of people. So trying to suck all that information down into what you think is the most important, that's the key. That's part of the process here. And I'm here to help you along with that. If you have questions and you can give me a couple slides and be like, what do I need to take away from this? And I can kind of walk you through it, and you can kind of learn the process so you can do it on your own. Some people do this naturally. A lot of people don't. So don't feel bad because you didn't get it down on day 1, right? That's the whole reason why you're here, is to learn. Anyway, I'm going to talk about this other one as we get into it later on. So I will mention this probably next lecture. So I'm going to leave that there. But anyway, thank you for joining me. I hear my little one downstairs is losing her mind, so I'm probably going to go check on that. And otherwise, you guys can have a great day, and I will see you later.